Our guest is renowned healthcare leader and author Dr. Robert Pearl, who says artificial intelligence will soon be as common in healthcare as the stethoscope.
What we're going to find that the technology is 10% better than the average clinician in an advice center or the average nurse in a chronic disease management program, or for that matter, potentially even the average physician doing inpatient care when there's 5 or 6 different doctors taking care of the same patient and they're not effectively communicating.
Dr. Pearl is a professor at both the Stanford University School of Medicine and the Stanford Graduate School of Business, which gives him a great vantage point to assess the challenges and the opportunities for healthcare in 2025.
If you're a patient with chronic disease, it can effectively manage your chronic disease by having you have wearable monitors that connect with the device that can do calculations and tell you, are you getting better or worse?
And this is Conversations on Healthcare.
Well, Dr. Pearl, welcome back to Conversations on Healthcare.
My pleasure to rejoin you. I look forward to our conversation today.
We do too. And Margaret, it was back in 2014. We had Dr. Pearl on. Lots has changed since then. At the time, you were the executive director and CEO of the Permanente Medical Group. It was really quite a fascinating interview because you discussed the battle between traditionalists and technologists in medical care. I'm wondering if it's fair to say 11 years later, the technologists have won.
Well, I think there's a new technology, and that's generative AI. And it's important that we differentiate it from everything that has come before, because this is the first technology in the history of medicine that I can think of that actually empowers the patient, not designed for the clinician, but for the patient, or it wasn't designed for that, but applicable to the patient. And in that way, you can say that the technology has evolved in a way that has led it, I think, to be able to be an equal partner with the human.
Well, when we look at that interview, and actually I remember this, and I'm reminded again, you had great enthusiasm for the future. I think enthusiasm is always good in healthcare and life generally. But when we spoke to you, none of us could have anticipated, I don't think, the pandemic. And with it, the growing skepticism about science that has come into the society. And I wonder, what are your thoughts about that? What's your advice for navigating this post-COVID era where there is such skepticism about science out there in general?
You're absolutely correct that the pandemic could not have been predicted for the year that it would come, but I think a future pandemic could obviously have been predicted, and we were not adequately prepared. But I would say the shift away from science today is very regrettable. It's going to harm people, cost lives. All you need to do is look at Texas, where currently there's over 500 cases, 600 children hospitalized, and 2 deaths.
Right.
That's 1 in every 8 afflicted children with the disease requiring an inpatient admission. And that number is 4 children per 1,000 dying. But as you know, the historical numbers have been 1 to 2 or 1 to 3. And that's what we're going to see if this unscientific approach to a very controllable controllable infectious disease persists.
I want to get back to your book because it has a great chapter titled ChatGPT, MD, How AI Empowered Patients and Doctors Can Take Back Control of American Medicine. And you say you wrote the book with the assistance of OpenAI's popular chatbot. Tell us a little more about how that transpired.
Happy to do so. First of all, I want to tell viewers and listeners that all profits go to Doctors Without Borders, a great charity, as have the profits from all my previous books. I wrote it because, as you know, November 30th, 2022, the generative AI, ChatGPT, was released. Now, I named it ChatGPT MD, my book title, because it flows so beautifully. But everything I'm about to say about ChatGPT is just as true about Gemini from Google, just as true as Claude from Anthropic, and the most recently released Chinese DeepSeek model. But what I realized is that this is an exponential technology. In that way, it's very different than something like the electronic health record. An exponential technology, actually like a coronavirus, doubles every year. And in this situation, the technology, ChatGPT, would be 32 times more powerful in 5 years. And in fact, if I went through the typical cycles I had with my previous books of going through a traditional publisher and writing it on my own, it would have taken about 2 years. By that time, the technology is 4 times as powerful. And everything I write would be outdated. So I said, how do I increase the speed, accelerate the writing and distribution process? And I decided that the way to do it, and by the way, an interesting way to do it would be to work with ChatGPT so that I could firsthand experience this generative AI tool, not just in clinical practice, but also in the creation of artistic work. And I approach it the same way I do with a resident or a medical student with whom I'm going to write a paper. In this situation, I gave ChatGPT the 1.2 million words that I had written and published. I would normally give a bunch of articles to a medical student or resident. And then we exchanged drafts back and forth, probably 30 different drafts per chapter. There's 6 pages in there, I should point out, that were written only by ChatGPT or mainly by ChatGPT. And I highlight those so readers can see how the technology itself would work. But all the others were, I'll call it a collaborative effort, and represents a combination of the voices that were there. And as you know, the book was then distributed, available on Amazon still today, bestseller, both originally and continue to be so today, on Amazon.com.
Well, I want to point out that the training of an AI instrument is very important, right? Where it gets its information. So I'm wondering if you sort of put the version that you were on, and if you would go forward in a year and maybe think about doing another rewrite, given how fast the improvement is going in AI.
You are absolutely right. When I wrote the book, the only way to enter data was by typing into text. And now you have visual, image, you have voice, so many different ways to do it. The time that I wrote it, the version wasn't even up to date. As I know, the book was 18 months behind. Now, by combining the training that's been done along with the availability of information on the internet, it's up to date right now. But I think maybe the most important part was just this release of the product called DeepSeek. This is an open source tool, unlike ChatGPT or Gemini or Claude. It means that everyone can access it, understand how it works. And the way this tool is created was not, as you're indicating, through downloading, through pre-training on the entirety of the internet and all material, all textbooks, all journal articles, everything available. It was done through a process called distillation. That means they took a currently existing model and extracted from it information, not by copying it, because you can't do that, but by asking it millions and millions of questions. And in that way, what you're able to do is to narrow the focus and go far deeper into whatever you're trying to accomplish. And then having done distillation, the next generation of generative AI tools is not only going to have the large language model capabilities, but it's also going to have additional training. Think about it this way. Millions of calls are made to advice centers. Millions of calls are done annually for chronic disease management. The monitors in every hospital record a terabyte of data annually, and that is 10 with 14 zeros, and 97% is thrown away and never looked at again. The opportunities to learn, to narrow it, to focus it on diabetes, or narrow and focus it on heart failure, or inpatient treatment, now will create tools that are not only easily available, easy to use, but they will also be very specific, and I believe that the ultimate acceptance of these tools will be done because the people will take the model and they will use the model and simultaneously in a research project have a human provide the same expertise or the same level of treatment, and then compare the two. And what we're going to find that the technology is 10% better than the average clinician in an advice center or the average nurse in a chronic disease management program, or for that matter, potentially even the average physician doing inpatient care when there's 5 or 6 different doctors taking care of the same patient and they're not effectively communicating.
Well, you're making it clear we're all going to have to stay around and stay engaged because it's way too exciting to miss out on what is about to come. But I want to maybe see if there's a leap we can make from what you've just said to what you referenced in your book, which was that healthcare providers and patients can join forces to reclaim from prevailing corporate interests more perhaps ownership, authority, agency. Explain to our listeners what you meant by that.
The challenge today, I believe, is the economics of healthcare, the fee-for-service system. This is a pay for volume. Charlie Munger, Warren Buffett's partner before he passed, said, show me your incentives and I'll show you the outcomes you're going to get. And certainly Warren Buffett's gotten great outcomes, but because the system has aligned around that. That's what I see in healthcare today, that what clinicians are driven to do by incentives, by rewards, is just do more and more and more. And as a consequence of that, I believe they're losing control, and patients as a result, maybe getting a lot more things done, but they're certainly not healthier. Life expectancy today is no better than 15 years ago. Maternal mortality in the United States is twice as bad as any other country in the world. Childhood mortality is the worst of any of our peer nations. We could go down an entire list. There are 400,000 people who die every year from misdiagnoses, not because doctors aren't smart. They just rush. They just have too much to do in a day. So the question becomes, how do you change this? And this is where I believe that what needs to happen is to move from a pay-for-volume, fee-for-service, to a pay-for-value capitation, a single payment made to doctors and hospitals, not to insurance companies, doctors and hospitals, to provide the care to a population of patients. What's interesting to me, what's very exciting to me is according to the CDC, if we could effectively control chronic diseases, we're talking hypertension, diabetes, heart failure, things like that, we would see 30 to 50% fewer heart attacks, strokes, cancers, kidney failures. We would save probably 500,000 lives a year. The cost of medicine would go down by $1.5 trillion. And why have we not been able to accomplish that so far? We haven't had the technology. And that's why generative AI becomes to me so powerful. If you're a patient with chronic disease, it can effectively manage your chronic disease by having you have wearable monitors that connect with the device that can do calculations and tell you, are you getting better or worse? If you're getting worse, you need to have a medication change. If you're doing better, you don't even need to see the clinician because you're doing well. This is the kind of power the technology is going to do. It provides expertise to the patient. When they have a new symptom, they can figure out what's going on, and they can decide whether they need to see a clinician based upon that expertise. That's why I don't talk about AI, I talk about generative AI, because what exists for the most part, particularly in the past, was what's called narrow AI. AI developed by taking 2 data sets, let's say women with mammograms, 5,000 of which show cancer, 5,000 of which are either normal or benign disease. And then they compare the two and figure out some discrepancies. And that works well for visual images. But generative AI is based upon the totality of all the information that we have, every medical textbook, every journal article. And now it becomes available to the clinician to look up a problem that he or she can't figure out. And it allows the patient, that I could give you dozens of stories of parents able to figure out what was wrong with a child when the medical system couldn't, or clinicians who, facing a situation, could go into the literature and find 4 cases, 5 cases, very obscure cases, and know exactly what to do. And that would have taken them days in the library. As I say, this is the dawn of a new era, and we shouldn't think of it as just another AI tool. This is as different from what's come before as the iPhone was from the telephone that was in most people's kitchens attached to the wall.
Well, certainly we want those important outcomes and results, but we also want to make sure that there's maybe a randomized clinical trial that sort of evaluates the efficacy of those. And I was interested to see that we found that when in a randomized clinical trial, when AI worked independently to diagnose patients, it achieved 92% accuracy, while a physician using an AI assistance were only 76% accurate. I'm wondering if you have some thoughts about that particular trial.
Absolutely. So the trial you're referring to was published by researchers at Stanford. It was done in conjunction with researchers at Harvard. It was a small trial, so I'm not sure the numbers will hold up when we're talking about thousands and thousands of clinicians. But what it points to is that humans have what's called confirmation bias. If you come to me and you tell me you have a certain symptom, and I immediately leap to a conclusion as to what the disease is likely to be, I am more likely to ask you questions, to be able to hear information that reinforce my belief rather than change it. These are the 400,000 deaths a year from misdiagnoses. And the reason why that happens is that doctors are rushed. You know, there's been some research done that said if primary care doctors did everything recommended by regulatory agencies for every patient who came to their office, it would take 27 hours a day. Not possible. So what happens is that doctors have to take shortcuts. It's not that they don't know what to do or they want to do something else. They don't have a choice today. And this is why I say we're on right now a treadmill where doctors are paid on a fee-for-service basis, that insurers keep lowering the dollars that are being paid while drug companies raise prices and salaries go up. So doctors have to see more and more people a day. They see on the average now a patient every 17 minutes. They interrupt the patient every 11 seconds, not because they are not dedicated, hardworking, smart, and want to do the right thing. We just have given them today an impossible job. And this, to me, is where the technology comes in. It can do a lot of the pre-work. It can do a lot of the post-work. It can manage these chronic diseases that patients have every day on a continuous basis, not episodic. It can provide care 24 hours a day, 7 days a week. I think done well, it could save hundreds of thousands of lives, make medical care affordable for all Americans, and lower the burnout. That, as I say, is a crisis with half of all clinicians affected by it in the United States currently.
Well, I'm going to pivot for just a minute from generative AI and impact and talk about the people side of this equation and our current moment in history. And you recently had some positive thoughts about our new HHS Secretary, Robert F. Kennedy Jr., and called him an imperfect leader at a perfect time. Take us through your thinking on that.
Well, I would call my perceptions, and I'll use the word balanced, although I really mean balanced only because both extremes are equally weighted, or both have weight on both ends of this long seesaw. I want to start with the negative side. I think that his views that he's expressed in the past around vaccines are unscientific and right now are contributing to the problems that we have in Texas and the deaths that we've seen. And I think there are other areas around some of the cutbacks. These are not driven by Robert Kennedy Jr., but by the overall administration that is happening, whether the FDA, the NIH, the CDC, that are going to have long-term, very negative consequences, not, by the way, only for the health of Americans, but it's going to set us back behind the rest of the world where we've been a leader in scientific advances. So I want all listeners to know I am not saying that he is the positive answer, that other negative side exists. But if there's a silver lining to his appointment, it's that he has been a very strong advocate for the challenges that our food industry produces. And what we know today is that obesity is a major problem. Over the past 20 years, it's doubled from about 22% of the population to 46% of the population. Its cause is very simple: the food industry. The foods that are being created are designed to be ultra processed, high caloric. They're designed to be able to give more calories per bite. And that is how we drive obesity in this country. And why that is so significant is obesity is the leading cause of diabetes, which is the most common reason why people get heart attacks and kidney failures, 80% of lower limb amputations. And it is also the cause of 40% of cancers. So we are talking about an amazingly terrible, a really terrible type of impact. And this is where in the article I wrote, we have yet to take on the food industry. Every time someone has tried in the legislative branch to put up the kind of effective approaches. What's an effective approach? Taxation. We see that in cigarettes. You raise the tax on cigarettes, people consume fewer. You raise the tax on sugar soda, they imbibe a lot less sugar soda than they otherwise would. Put a tax on these high caloric, high fat, ultra processed foods and use that money to subsidize fruits and vegetables, the kinds of things that many Americans simply can't afford. And now you have a possible recipe to reverse the pandemic. You add to that some things like the GLP-1 drugs, so that people can start the process of losing the weight along with diet and exercise lifestyle and food changes. Now you start to have a more effective way to be able to reverse this obesity crisis. And now you add to it some of the things that the health secretary has said, which is that primary care is very important. And we know that it is, and we know that every incentive in the fee-for-service world goes in the opposite direction. It tends to drive more specialists, more inpatient care, more procedures. We are a nation that treats sickness and disease after it happens, and a nation that ignores the ability to prevent these problems before they occur. And I'm hopeful.
Yeah, isn't that if you listen to some of his top aides, Callie Means really sort of characterizing the health system as utterly failed, that we spent more money than any country in the world and have worse outcomes than all of them. You look at some of the things they're proposing on the SNAP program to end the access to buying soda pop. So they're very focused on a whole different side, and you just touched on it, which is to prevent disease, increase longevity, versus what you were talking about, managing diseases. That's a whole paradigm shift, forgetting all the other politics, just sort of thinking about it, what many people have said for a long time. We're just spending an inordinate amount of money on our healthcare system and not getting the outcomes that we would love to see, but we're simply maybe taking the wrong approach. Do they have something there?
Absolutely. I mean, you've described it perfectly. And what I said earlier, we talked about capitation in 1934. That's 100 years ago. We recognize the problems created by the fee-for-service system, but at every point it has been blocked. We've known about the challenges of food, the ultra-processed food, the way that obesity has been a rising crisis for 20 years, 25 years. These are not new problems, and yet we can't get out of that. Yes, I'm hoping that the secretary, along with the people he's appointed to lead various agencies, will take us in that direction. There's an expression I like that, the impossible becomes possible and then inevitable. This change is inevitable. The only question is how many people need to die prematurely before we actually make the changes that we know will be effective.
Well, I agree with so much of that, and all the universe of spin-off challenges arises immediately as we think about them, right? So we've all been engaged in healthcare delivery and also training the next generation of people who are going to deliver that care. I haven't I haven't heard the same kind of clarion calls for revamping, not just of the education and training of physicians, but the education and training of nurse practitioners, of social workers and psychologists, physician assistants, of all the people, the community health workers who are going to have to drive this shift. And I wonder what your take is on that. Do you think it's going to be a case of 10 years or 15 years till we really revamp our curriculums to drive towards this kind of focus? Or do you have some insights into that and what federally we ought to be doing about it?
In my second book on caring, how the culture of medicine kills doctors and patients, I look at the educational process in detail, and I point out that it is always at least 20, if not more years behind, because the people who are doing the teaching are the ones who received their training 20 years in the past. And they still see that as the best way because they see themselves as being the best practitioners. It's just natural. It's the human tendency. And, certainly quite a number of people have written about all of these I'll call mental mistakes that are written. People won Nobel Prizes for the literature they've created around it. And we just see that very much. I have little confidence the academic institutions are going to change. You can completely alter the medical school curriculum. You can make generative AI not just a tool that people are taught around, but they are forced to use as a medical student or resident. The systems that we have for admission, for evaluation, for certification, they test memory. Memory was a crucial skill 30, 40 years ago. If you wanted to carry around all the medical information with you, you need a 50-pound backpack. Now we have tools. Just ask generative AI a question and you will have the answer in a matter of seconds. Why should we not be using this tool? But I agree with you completely. I think the academic institutions are not going to do it. And this is going to be a classical type of disruptive change, change that has been well described by Clay Christensen, where the people, I'll call it with the least power, are the ones who start to embrace it. And as they start to use it and it gets better, then people with more ability until ultimately it penetrates the whole system. And who has the least power in American medicine today? The patient. And I think it will be patients who start to use it. Then you're going to see primary care physicians. Then you're going to see specialists. And it's already happening, by the way. I can't give a talk, and I gave 50 keynotes this year to conferences about the future of healthcare. And I have 40 more scheduled coming up. This is the hottest topic out there. And I can't go anywhere where I don't hear stories. I heard a great story. I was at Stanford this summer teaching a program to 80 CEOs from across the country. At the end of the program, one of them came up to me and said, Dr. Pearl, I had never used the tool. While you were talking, I registered for ChatGPT. I entered information on my daughter who had a very baffling disease that I took out of 6 different academic centers over 18 months. And I asked for ChatGPT's differential diagnosis. And it gave me 3 diagnoses. The number one was a very rare inflammatory disease, which is exactly what we learned 18 months after we started seeing academic experts in various medical centers across the United States. This is what people are doing. You see it in the surveys and was noted earlier. What we're seeing right now is this technology is highly reliable and it's excellent. It's not that it's perfect. And people should understand that. This doesn't replace a doctor today. When I wrote the book, ChatGPT MD, I fact-checked everything that ChatGPT told me, 30-page bibliography. And I found only one big mistake, and that was an expedition to the North Pole that had hallucinated. But it still was a mistake.
Well, let me get at that. Let me get at that issue of the future of medicine, about trust in medicine, and about AI, because it seems to me that doctors and other medical workers fear the falsehood and conspiracy theories that are eroding trust in their profession. And I'm wondering if you think AI is friend or foe in that battle, because there are many other examples where the footnotes, in fact, had half of them were hallucinated. So what's your sense about how we're going to get at medical trust? And does AI help us restore medical trust? Because if we're going to have people like yourself speaking, if we have people who aren't listening because they've lost trust in the healthcare system, that's a real problem.
Well, there's trust in the healthcare system and there's trust in the technology. And I'm not sure which of the two you're most interested in. In terms of the technology, I think it's going to increase the trust with the clinician. It's going to do it in two ways. Number one, it's going to give doctors the time that they need to be able to minimize the errors of today. We don't think about that. We ask about the technology could harm someone. We don't think about that in the context. What will it do to 400,000 misdiagnoses? What about if it reduces it to 200,000? That's still 200,000 people who die, but it's half of what exists today. But maybe it's 100,000. Maybe it can get it down to 50,000. I don't know how far it can go, but it can create that. And the second thing I think it's going to do is it's going to improve the dialogue. It's going to actually make the doctor-patient relationship better. Why do I say that? I was on a podcast where the host said to me at the end when we were off air, could you give me your advice? You're a doctor, you're a skier. My husband fell 3 months ago. His arm was over his head. He slid down the mountain 100 feet. His shoulder still hurts, and it doesn't work as well as the other side, the arm. What's going on? I said, I think I know exactly what he has. But do me a favor. You said you'd never use ChatGPT. Why don't you put all of his information in there, see what it says, and then call me back? She calls me back 5 days later, and what does she say? Thank you so much. It said he most likely had a rotator cuff tear, that he needed an MRI to find out which tendon was damaged, and he needed to see an orthopedic surgeon in order to have the tendon reattached before the muscle contracted. And when they went to the doctor, he said exactly that. He said, you probably have a torn rotator cuff. He ordered the MRI. They knew exactly why that was going to happen. And when he said, you need surgery, they said, thank you. And by the way, at the end of the operation, he successfully reattached the tendon. But if he'd come 3 months later, I probably couldn't have done it. That's the power and the expertise. It's a better relationship. It's not a more problematic one. Now, in terms of the overall system, the system needs to be changed. That's why I've written these other books as well, because it is fragmented. Doctors are scattered across the community, unconnected with each other. It uses this pay for volume, this type of 19th century cottage industry means of piecemeal reimbursement. The technology, by the way, doctors use today, the most common way they exchange information is the fax machine. I tell my students in the Stanford Graduate School of Business, they communicate with a fax machine. They say to me, what's a fax machine? There's no leadership structure out there capable of making the change. Yeah, we need to change medicine in order to reestablish that trust. But it is the generative AI tool that will empower the patient and the doctor. And just compare that to the difference between doing that and clicking on a Google link, where you get 100 pieces of information. A lot of it is, by the way, misdiagnosis. It tells you 100 different reasons why arms don't work as well as the opposite side. And there's no way to personalize it, to figure out what is it that I have, that my loved one has. Generative AI is going to be the tool to accomplish it. Maybe 3 years from now, 4 years or 5 years from now. But right now, everyone should be experimenting with it and seeing all the things that it can do.
Well, there's no question about it. It has an important role to play in the world, in health, and certainly towards our guiding light, which is healthcare as a right and not a privilege for everybody. So thank you so much, Dr. Pearl, for joining us. I don't think we'll let 10 years go by until our next conversation with you, because obviously...
Yeah, I'll add, I'm absolutely convinced that a dedicated clinician with an empowered patient and a generative AI tool will be able to accomplish 10 times more than any of the three alone. Now is the time for us to begin the process, not the time to totally allow it to end. And in beginning the process, I think that we will come up with the best models for the future and hopefully change overall healthcare delivery in the United States and make us once again the best in the world. Thank you for having me today.
And health. Thank you, Dr. Pearl, for joining us. And thanks, of course, to our audience for being here. Just a reminder to be sure and subscribe to our videos on YouTube. Find us on Facebook and X. But please also share your thoughts and your comments about this program. Take care. Be well. This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.